Okay, so this is a lecture where high-tech meets low-tech. We're going to do a video, but we're going to do it with the old-fashioned dry erase markers, and we're going to talk about something that you've had before and hopefully maybe give you slightly different spin and help it cement it in your brain a little bit better. So this is for the integrating your pharmacotherapy. So I'm going to talk about penicillins, then I'm going to talk about cephalosporins. The core penicillin, the beginning of it all, is Pen-G IV or Pen-VK orally, and that is your core penicillin molecule. It used to treat a lot of things. Over time now there's a lot of resistance to it, and so basically it gets gram positives, and by that we pretty much mean strep, because almost all staph now makes beta-lactamase, and that's Staph aureus, Staph epi, doesn't matter, they make beta-lactamase. And so if you happen to find a staph that hasn't learned how to make beta-lactamase, penicillin is still the most active drug against it. It's a great drug. It's just that the odds are against it, and you just can't, you basically just assume that staph is going to be resistant to penicillin. So, as you remember from Dr. Nybo's lecture, you can modify penicillin in two different ways. You can make it beta-lactamase stable, or you can make it broaden the spectrum. Now, it sounds sort of like a joke when we say we broaden the spectrum of ampicillin, because ampicillin is not a broad spectrum antibiotic anymore. Used to be, not anymore. However, you do gain several things. You get Haemophilus influenza, and only the ampicillin sensitive Haemophilus influenza, which are the 60% or so that haven't learned how to make beta-lactamase. You get a few E. coli, Proteus, some easy gram negatives. Again, many of those have become resistant to ampicillin as well. So more and more ampicillin, and this is ampicillin and amoxicillin now, I should have said. Amp is IV, amoxicillin is oral. And more and more, these drugs are becoming to be more and more similar to penicillin as more and more bugs get resistant. You will see that, for instance, in dental guidelines now, you'll see large doses of amoxicillin when it used to be penicillin. Reason is amoxicillin is reasonably well absorbed, whereas penicillin is only about 50% absorbed. A lot of it gets destroyed in the gut. So this drug is being used kind of as a penicillin now because the spectrum has become reasonably narrow. Oh, I should have mentioned also, you do get mouth anaerobes, the easier anaerobes. Streptococcus, Strep intermedius, Strep viridans, the whole group of Strep viridans, you get with penicillin. When you go to this, you keep that activity, you don't lose that, and you gain a little bit of spectrum, but not much. Now you can go to even further broaden the spectrum of penicillin, and you can get to the piperacillin type drugs. And I'm going to talk primarily about piperacillin. There's also ticarcillin and other drugs that don't get used very much, but primarily it's piperacillin. These drugs are, I would call them good but not great against space bugs. However, they do get Pseudomonas. So piperacillin is a good Pseudomonas drug. But when we're broadening the spectrum down the gram-negative range, we are not adding anything in terms of beta-lactamase stability. So you don't get ampicillin-resistant H. flu. Even with this, you don't get ampicillin-resistant H. flu. You don't get any staph coverage. You don't get any anaerobe coverage except for the easy mouth anaerobes, but you don't get Bacteroides fragilis or any other Bacteroides. You just get more and more gram-negative coverage. And I have two P4s sitting in the room. Chad's manning the camera back there, and Teresa's just going to tell me all the dumb things I say. So you guys, honestly, ask questions, jump in, because that's going to help everybody. They're not going to be able to hear your question, but I'll repeat it. So if something isn't making sense, or you haven't heard it before, or you want clarification, jump right in, because it's just going to make the talk better. Okay? All right. Now, so that's the gram-negative broader spectrum arm of penicillin modification. You can go to the beta-lactamase stable penicillins, and this is classically methicillin. And I say classically because when we talk about bugs becoming resistant, like methicillin-resistant Staph aureus, we use methicillin as kind of our prototype. But over here you also have nafcillin, the cloxacillin, the dicloxacillin as well. But all of these are modified, and I'm sure that Dr. Nybo has clarified the structural reason, so that they are stable to beta-lactamase, so they can't get broken down. Be careful when you use your terminology, because there's beta-lactamase producing bacteria, there's beta-lactamase resistant or susceptible drugs. Be careful to remember whether you're talking about the drug or you're talking about the bug. Okay? So all these do is you add staph coverage. That's really their whole function. These are very good staph drugs. You're adding the beta-lactamase producing staph. Now, the staph, before very long, got smart and started changing their penicillin binding protein to produce methicillin-resistant staph aureus, methicillin-resistant staph epi, and so there are bugs that are resistant to this, but these are still great drugs for a lot of staph that are methicillin sensitive. Okay, all good so far? Now, as you know, we now have been able to add beta-lactamase inhibitors to these drugs. So if you add beta-lactamase to ampicillin, that's ampicillin sulbactam, brand name Unison. And then if you add it to the oral drug amoxicillin clavulanate, that's Augmentin. And so what do we gain here? That's the question. What you gain here is you gain, I'm going to put it here, methicillin sensitive staph. So if these drugs work, this drug is basically generally going to work, because you've defeated the beta-lactamase of the staph. You also get ampicillin resistant H-flu, because ampicillin or H-flu resistance is mediated through beta-lactamase. You also get B-frag, and these drugs actually become pretty good broad-spectrum anaerobic drugs. Augmentin and Unison, amoxicillin clavulanate, and ampicillin sulbactam. So this become actually fairly. Oh, and sorry, a few years ago, E. coli started getting smarter about making beta-lactamase, and so ampicillin became a pretty bad drug against E. coli. You get a lot of those back when you inhibit beta-lactamase as well. So that's a big change when you add a beta-lactamase inhibitor. Likewise, if you add a beta-lactamase inhibitor here, tazobactam, you're going to do the same exact thing. You're going to add staph coverage. You're going to add ampicillin-resistant H-flu coverage, B-frag coverage. E. coli, probably not, because E. coli beta-lactamases probably don't work here, and you probably already cover a lot of E. coli with piperacillin alone. By the way, piperacillin alone, I think, is a great drug. It's active against Pseudomonas, and it is narrower spectrum than adding the tazobactam. However, it's not readily available and nobody uses it. So as much as I want to dream about being great, the truth is we're not using those. We're not using piperacillin alone anymore anywhere. It's just gone. So, piperacillin tazobactam. Tazobactam does not improve the Pseudomonas coverage because Pseudomonas resistance isn't beta-lactamase mediated. And you might want to know what it is mediated by for an exam question of some time in the future. But it does add back the BFRADs, the ampicillin-resistant H. flu, the methicillin-sensitive staph to this already pretty broad-spectrum gram-negative drug. So this becomes a powerful broad-spectrum drug useful for things like intra-abdominal infections and diabetic foot ulcers. All right, I think that wraps up my sort of penicillin organizational thought. Do you guys have questions? The things that aren't clear, is that all making sense to you? Got no questions. Okay, excellent. So must be crystal clear. You stop the camera now.